Well, thank you very much, Alex. It's a pleasure to be able to come to speak to the group today. I see we have a nice number of people. My task will be to keep you all on without having to hit the end button. So let's try and keep that as much as we can. I'm going to be speaking on back pain tonight. And normally this lecture that I do is about 2 hours long, but we've got 45 minutes with 15 minutes or so for questions afterwards. So I'm going to try and give you a whirlwind tour of the presentation that I have. And as Alex has indicated, if you have some questions as you go along, throw them into that chat box. I'm not very good about seeing them as they're running questions. I don't really watch them that much because I'm just, I have suffered from a chronic verbal diarrhea, so I will just keep on talking. And so we will be able to address some of those questions at the end, but it's a good idea for you to write them down as they come to mind so that you don't forget them. That'll be a great thing to do. So as indicated here, we're going to be talking about back pain. And ironically, I have, as of Tuesday, I've been kind of down and out with the back pain of my own myself as well. And probably part of it is COVID related because not having being as active in things, and I chose to do some work on one of our vehicles, which ended up being work underneath the dash of the car, and I was in a contorted position there for about 2 hours, and I irritated a facet joint, I think, in my low back, and it's been a problem for the last 2 or 3 days. It doesn't seem to want to be settling down, but it's coming. So, anyways, we're going to talk about back pain. I'm going to be, if I flinch once in a while, you'll know why. That's because I'm one of those. And in keeping with that, in terms of the prevalence of back pain, it is one of the more common ailments that we have, that people will have. And in fact, as many as 80 to 85% of the adult population will experience back pain. So it's probably pretty safe to say that a large proportion of you already, of the people that are participating here tonight, have had back pain. And if you haven't, you may have it at some point in time. It is the number one cause of absenteeism in the workplace. And of course, it has huge implications, economic implications to the health system, particularly in absenteeism and loss of productivity in the workplace. And so it really is an important thing for us to discuss, and more importantly, to understand. And I typically, when I present on these kind of things, my goal really is to get you to really maybe have more insights into it so that you can actually answer your own questions. And so I like to take things apart, and I like to show you what it is and what the structure is, and try and get some understanding about the stresses that are put on those structures. And then you can kind of understand a little bit about what we refer to as the MOI. The MOI is the mechanism of injury. Basically, how do the injuries happen in the first place? So we're going to talk about what back pain is. We'll dissect sort of the back to some degree from an anatomical perspective. And then we'll look at things, now that you have sort of understanding of the anatomy and in part the mechanism of the injury that happens, how do we go about preventing these things from happening? And and then the third part of this is, if you do have an injury, what are some of the treatment things that you have at your disposal? Right. So the first thing what we'll do then is to just look at the anatomy of the spine, and the spine itself is if I say so myself, it's not a very well designed structure architecturally, at least from the standpoint of the Homo sapien, i.e., you and I who stand upright. It really doesn't make any sense from that standpoint when you take the spine and turn it upright like this. On the other hand, if you were a quadruped, if you were a person who walked on all fours, or if you're an animal, it makes perfect sense. And so this is where the design came from. Before man started to walk, this was a design that was in dinosaurs, etc. That this made perfect sense. In fact, I always tell the story that I remember years and years ago traveling to Calgary for a basketball game with the University of Manitoba. And I remember going into the baggage area and seeing this huge skeleton of a dinosaur. And at that time, I was just finishing my anatomy. I might have been, and in fact, I was teaching our lab instructor anatomy. And I went up and I looked at the structure, and I looked at the bones of the spine, and I go, these are huge and they're massive. And sure enough, they've got all the same sort of structure that we have. But then when I saw it in the horizontal plane, looking at it sideways like this, it made perfect sense. The way the design is, it's made perfectly for being horizontal. It is not made perfectly to be upright like this. So, but this is what we have. This is what we have been left with, and this is what we have to deal with. And largely because of this architecture is why we have the prevalence of back injuries that we have, and why we need to be so cautious about taking preventative precautions. So essentially, I'm going to take you a little bit of anatomy, and I'm going to say there are in total 33 bones that make up the whole of the skeletal structure, all right? And the first seven are in the neck. These ones right here. And they're very small vertebrae, and they're very mobile. And so when you think about how much you can rotate your neck from side to side, up and down and off to the oblique sides, etc., it's a very, very mobile set of bones. They move a lot on each other. And because they're mobile means that the opposite would be stable. And these are not very stable joints, and therefore they're more prone to injury. So we more often hear about people sustaining neck injuries more than we have low back injuries, particularly in things like car accidents when you have whiplash-related mechanism of injury, or a diving accidents in a pool, et cetera, et cetera. But they are very small vertebrae because they don't bear a lot of weight. The responsibility there is more for mobility and not for weight bearing. It only has to pick up the weight of the head, which is about 10 pounds. So they're not very big, and they're very mobile, and consequently, they are also vulnerable to injury. Okay, so we'll move back into that in a little bit. Now, the next 12 vertebrae are in the trunk. So these next 12 vertebrae over here are in the trunk, and their prime responsibility is that they're the attachments for the rib cage. And so the rib cage now attaches onto that and protects all of your internal organs, your heart, your lungs, your liver, your stomach, your kidneys, et cetera, et cetera. So they provide this cage of this bony armor around those vital organs. And they also have to bear more weight, force of gravity, because now they have to bear not only the weight of the skull, but certainly the weight of the cervical spine, and also every vertebrae as they move down. So these vertebrae, the thickness of these vertebrae, the size of them increase as they go down from T1 through to T12. Okay, 12 thoracic vertebrae, T1 at the beginning, T12 all the way down to the bottom. All right. They don't have a lot of mobility. You can twist your trunk a little bit, you can side bend to yourself, but they're less mobile than the cervical spine. Therefore, they're more stable. They're stiffer, and they don't succumb to injury nearly as much. All right. So we don't see a lot of mid-back pain when it comes to the thoracic spine. The next 5 vertebrae of the 33 are referred to as the lumbar spine. So it's these next 5 vertebrae right here. Okay. And now those vertebrae, when we look at them in a second, you're going to see just how big and large they are. Like this body is called the vertebral body, very thick bone. And they get thicker and thicker and bigger as they go down from L1 to L5, lumbar 1 to lumbar 5. They get bigger and thicker. Why? Because their prime responsibility is weight bearing. So not only do they have to bear the weight of the skull, of the cervical spine, and the thoracic spine, all of the ribs that are attached onto it, but also all the other organs that are now bearing weight on you as well, and all the muscles that are on your body. These are all pulling down by being pulled down by the force of gravity. So they're putting a lot of weight on your spine. So these last 5 are largely related to weight bearing, and they don't move as much as well. So certainly, we can flex forward and backwards with our low back, but we can't rotate as far to the right or to the left with our low back as we can with our head. So they're stable as well. Okay. But because they have a weight bearing responsibility, some of the injuries that happen are pure because of overuse and overweight bearing on what they're having to do. Now, so we're looking at these in what's referred to as an anterior view. You're looking at them from the front. Okay, so we've taken all this rib cage and all the muscle and all the organs away, and we're looking at it at the front of that. And then, so we got these 5 lumbar. The next 5 bones are what we refer to as the sacral bones. And if you look at, this is the sacrum. Another name for the sacrum is your tailbone. And if you look at these now, you say, well, I don't see 5 different bones. But what's in fact happened here is because these are the ultimate weight bearers of the total spine, because at the very bottom. And their responsibility for weight bearing is so great that these vertebrae have actually fused. So if you look at, there's 1, 2, 3, 4, and there should be 5. Well, there'll be one at the top. Yeah. So there's these are, where you see these holes here, these are separate vertebrae, but during evolution, they have fused. Now, if you were a dog or a cat, they would be part of your tail, and there'd be some mobility there. And why don't they fuse there? Well, because they don't have to, they're not upright, right? So they got more mobility to them. But in a human, they have fused. And so they're the ultimate weight bearer of the total upper body on those bones. So obviously, there's very little motion that happens here. Of course, there isn't any motion happening there because they've fused. So this is not a very mobile joint, but it's a very, very, very stable joint. And it's designed for weight bearing. All right. So that's an important thing, just kind of look at that perspective. Now, the other thing is looking at it from the side. So you can see here's your tailbone right over here, that's the bottom. And then we've got the vertebrae, and you look at, they've got these curves built into them. And they would be sort of the same thing, if you're thinking about, I remember when I was a kid, we used to have building blocks, the blocks with the ABCs on them. And you would want to sort of put them one on top of another. And as you maybe put 3 or 4 of them on, all of a sudden it started to waver. So what you would do is you'd offset it by pulling one of the blocks just off a little bit. And you go up and up and up, and then it would start to waver. And suddenly you sort of balance it off by putting it off the other way. That's essentially what's happening here, is that we started to put one vertebrae on top of another vertebrae, and we started losing that stability. It became off balance. So to try to recreate balance, we would curve one way, and then we're curving too far that way, so we would start to curve the opposite way. And there are these natural curves in our spine that happen that give us provide us with sort of some stability, some balance of the spine in the upright position. It's really quite interesting that when you think about how these developed, but we're not going to go through a lot of that detail because we don't have a lot of time. But just to say that the cervical spine, this is called a lordotic curve, a curve where the curve curves more anteriorly, or you got a like a concave posteriorly, convex anteriorly. That's a lordotic curve, Lordotic, lordotic curve. And we have a lordotic curve in the cervical spine. And that develops when the baby develops. That's the way that develops is when we have our young baby and they're on the floor and you've got them finally that they can start to play on the floor, but they wanted to look and see what's going on. So they use their neck muscles and they lift their head up and they look, and that's how they start to develop their lordotic curve and the muscle structure to do that. And then when you have them sitting up, well, they can't have if they got this curve in their neck and you try and sit them up, they're going to fall backwards. So the way they compensate for that is to curve the thoracic spine the opposite way. And this curve is called a kyphotic curve. Of course, then when you stand, the baby starts to learn how to stand, and you say, well, holy smokes, my head is way back, and I've got this curve here. I got to find a way to balance those two out a little bit more. And so I curve my lumbar spine in the opposite direction, again, or lordotic curve. So I got a cervical lordosis, lumbar lordosis with a thoracic kyphosis, and then my tailbone is the last kyphotic curve. So these 4 curves offset each other to try and balance and give you an upright position. All right. Now, this is looking at your tailbone here from the back. and you're going to see these little bony things. We're going to see them a little bit better. You see these little bones here. Those are called the spinous processes. So you look at them, you can see them over here. And those are the things that you would feel if you were palpating the back of your neck and you felt those little bumps, little bony bumps. Those are called the spinous processes. One of the things that I've talked about this weight-bearing responsibility. I've talked a little bit about mobility responsibility, but one of the primary responsibilities for the spinal cord is the spinal column is to protect your spinal cord. And through the middle of this cord, this is a hole that creates a canal all the way down, and down goes your spinal cord. And we're going to look at that in more detail. All right, so we'll go look at that in just a second. So just looking at some vertebrae now from the side, we just take two of them. These two happen to be in your lumbar spine, in the low back area. And this is the front of your spine, and this is the back of your spine. These are those bumps that we were looking at just a second ago. These are the spinous processes right here, okay? And this is called the vertebral body. And it's the vertebral body's function is to bear weight. And we're going to look at the back portions here, how they articulate later on. So we've got this vertebral body, one vertebral body on top of the other. And in order to provide some mobility, that we have, these are segmental bones, but that means that in between each segment, between each bone, we're going to have a disc. And it's a fibrocartilaginous disc. It's like a rubberized type of disc. It's got some shock absorption to it. It's got some give to it so that we can actually get some forward flexion and bending and side flexion and rotation of our spine. So ideally what we would like to have had to protect that spinal cord was a rigid bone in here. Just have one big bony tube, and the spinal cord would go through, and the spinal cord would be perfectly protected, but we'd have no mobility. So the design of the spine is such that we're providing that canal for the spinal cord to go through, but we're also making these bones segmental with this little movable disc in here. And whenever we do that, we take away that stability and compromise it with some mobility. So now we make ourselves more vulnerable to injury. So this is one of the reasons why we have these injuries, because we have this mobile structure and we put an awful lot of stress on it, as we're going to see in a second. All right. So we're going to look a lot at this disc in a minute. This is the yellow you see here is the spinal cord coming down from the brain. All right. And it's going right through the canal. So each one of these vertebrae has a hole in it and creates a canal. And at every segment, so let's say that this is let's say this is the fourth lumbar vertebrae, and this is the fifth one. So it would be right here. This is the fourth one here, and there's the fifth one. Okay. So we have the disc in between, and at every segment you have a nerve that comes out from that on both sides, left and right side, and those become part of the nervous system. It's like the telephone wire communication that we have. All right. So that's looking at it in an illustration. Here's looking at it in an X-ray. That we have an X-ray, and what we're looking at here is we're looking again the vertebral body. Right? I should I'm going to delete that. Whoops, hang on. Okay, all right. So there's a vertebral body, and then in this space where you see this dark space right here, that's where the disc will be. But an X-ray doesn't show you soft tissue; it just shows you bone. So we make the assumption there's a space here, but it really is not. It's filled with this cartilage disc. And when we look at it on X-ray, we always want to see just how wide is that space, because it gives us an indication of how healthy the disc is. And one of the other things that this disc does, in addition to giving you mobility and shock absorption, it also keeps these two bones apart, separated apart. And when these two separate apart, we create this hole. You see, right? That hole is right there. Okay. And out of that hole is the nerve we just talked about right there. So the problem would be that if the disc were narrowed down, it got thinner, these two bones would come closer together, this hole would get smaller, and likely it could pinch this nerve, and then I would get neurological pain, which we're going to talk about. Pinching the nerve creates pain, creates numbness and tingling, and causes muscle weakness. All right. So We want these discs, the disc in between to be nice and thick. We want these two bones to be far apart because we want this hole to be big so that it doesn't pinch on the nerve, okay? Now, this is a picture of an MRI. And an MRI shows you bone and it also shows you tissue, soft tissue. So now we're actually seeing the disc right there. Okay, we're actually seeing that disc in there. And we also see in here the spinal cord. There's your spinal cord right there, running down the whole length. Okay. Sorry, my lines are not going very well here. Okay. So that's the whole spinal cord. Now, one of the things that you're going to see, and it goes all the way down in here, one of the things you're going to see here, here's your disc over here. And you're going to see that that disc, something's happening in that disc, it actually got a bulge in it. It's bulged out. All right. And if I go to, I can't take this away now. I just do it and I don't know how to take it away. But so what happened there is the disc now pushed in and it's now pushing against the spinal cord. And you can see it over at this level over here. See, here's your spinal cord and here's your spinal cord. And look at that disc. It pushed the spinal cord. So it's putting pressure on that spinal cord. And we're going to talk a little bit more about that in a second, about the implications of that. But I kind of wanted to show you some of those things in X-ray, etc. All right, I want to spend a little bit of time on the intervertebral disc. And the intervertebral disc is the mainstay of this whole presentation, really. We need to sort of understand what this is. So we've talked a little bit about where it is. We talked about the fact that it's a shock absorber. It mobilizes things, and it also keeps the two vertebrae apart to make that hole. By the way, that hole that you have right here, this hole that we see right here, that's called the intervertebral foramen. Foramen means a hole, and it's a hole between the two vertebrae. Okay, so that's one of the reasons it's there. Now, if we look at it, and let's look at it in a little more detail, then we see that it's called the fibrocartilaginous disc, but it's made up of two different parts to it. First of all, it has what's called the lamellar rings. And so the lamellar rings are the outermost fibers of the ring, and they're layered. That's why they're called lamellar. It's like it's reminiscent of the rings of a tree. So those annular rings or the lamellar rings of the tree, this is reminiscent of that. So when you looked at the disc, you say, well, there's all kinds of different layers to this ring. Now, I want to show you a little bit. If I just take this very top layer, and you see these lines that are incorporated in there, those are there to represent a specific structure inside that sheath, that layer of tissue. It's a thin layer of tissue, but it actually has structure to it. It has struts, okay? And these struts are made up of what's called collagen fiber. And they're there to provide you with some stability. They're like the skeleton of the thing, or the scaffolding of that layer of tissue. And the analogy that I use is, if I take a straw, and I'm sure you've done this in the past, you take a straw and put it between your thumb and your finger, and you try and break it. You want to try and break it, and you can't, because the strut is in direct alignment to the line of force, this pushing like this. So if I was coming in and designing this disc, I would come in and say to the architect or the engineer and say, listen, I'm putting together this spine, and I want to put in this disc to kind of give me a little bit of, I don't want a rigid bone. I want a little bit of mobility. I want a little bit of play in that thing so it moves a bit. So I want to put a disc in. But one of the things this thing is going to be standing upright, so it's going to have all kinds of force of gravity on it. So it's going to be pushing down. So what can you do to prevent this disc from squashing, from these two bones squashing it? They would turn around and say, well, that's simple. And what you would do then is you would create a scaffold, and you would have that scaffold in direct alignment, perpendicular or parallel to the force of gravity coming in. So if I wanted to take this thing, take those two bones that are on top of it and squash it, well, this structure would stop it. And they said, perfect. It sounds like a great idea. That's the best way that way for sure the disc is not going to squash. and this makes total sense. But, actually, I also want this thing to be able to move a little bit, and I want it to be able to twist side to side. So he said, well, if you want it to twist side to side, the best way to do that would to take this strut and put it in a horizontal fashion, have it horizontally related, so that when I twisted, this would now resist a tearing because it's now parallel to the line of force. And I said, well, that's a great idea, except I really wanted to do both. I want to have it to resist compression, and I also want it to do rotation and movement. And he's going to say, well, if you want to have both, there has to be a compromise. You can't have 100% in either one of them. You have to compromise. So the compromise was, well, let's put these struts at an angle, okay? And that are about a 65-degree angle. So they're not a perfect compressor, and they're not a perfect resistor against horizontal stresses. But they're okay. They're kind of a jack of all trade. And then I turned on and said, well, I can see where, on this layer here, if you've got it at this 65-degree angle, that when I twist to the right, I can see where this is going to resist that motion. But I also want the person to be able to torque to the left. And so I need some protection there. So the architect will say, well, you've got all these rings. So here's what I'm going to do. This layer, I'm going to angle the strut this way. And the next layer, I'm going to angle the strut the other way. So you can see that line strut that way. And the next layer, I'm going to angle this way. And I'm going to offset them all. So now it's a compromise again, because only half of the layers are going to protect you going right, and half of the layers are going to protect you going left. But you're getting what you want. You want this mobility, and you want a certain amount of protection, but you're not getting perfect protection. So are you okay with that? Yes, we're going to live with that. All right. So that's kind of an interesting thing about the design of this. And we're going to talk more about this in a second. The other thing, the second part, is this center portion here. And that center portion is called the nucleus because it's in the middle. Pulposus because it's made up of pulp-like material or a gel-like material. It's a thick, fluidy, viscous type material. It's got lots of water in it. All right. And it uses what we refer to as hydrostatic pressure. So what it is, if I look at that disc in cross-section now, and you see all those rings that you have that circle around this whole thing, and there's your two vertebrae, one on top of the other, and there's this force trying to push down against you this way, force of gravity that way, and you may also be getting, when you walk and you're getting a ground reaction forces going the other way, this way, or you jump or something. And so something's got to stop. So we want to say, well, I want to stop these things from compressing. So we use hydrostatic pressure. This is fluid. This is water, much more of a watery medium. It's gel-like, but lots of water content in it. And hydrostatic pressure is such that the more you push against water, the more water pushes against you. This is what hydrostatic pressure is. And you've all experienced that if you've been in the lake, for example, and if you're chest deep in water, and if you walk through the water nice and slowly, it's pretty effortless. It's not a lot of work. But when you try to run through that water to get through it really fast, it's really hard, because the harder you pushed against the water, the more it pushed against you. That's a beautiful principle, because now what we're saying is the more compressive load we have pushing down on the disc, the more that this little guy that's in here is going to resist and push away. It's going to push out, and it's going to push up, and it's going to push down. And that pressure is now what we depend on to stop this disc from compressing. And so that disc now is keeping those two vertebrae apart, as we saw a second ago. It's keeping that intervertebral foramen open so that the nerve coming through there is not being impinged. All right. So we're starting to see some of that importance of there. All right. So that's this whole notion of disc compression. It's quite a fascinating thing. Now, one of the things that we talked about is this mobility thing. And so I've got two pictures here. If I have a person going into flexion, they bend over this way. Well, what happens when they bend over that way? This is the vertebrae that's doing that. So that means that this vertebrae is now moving in that direction, right? And when it's moving in that direction, because I want to bring my whole body forward, what it does here is it pinches the disc, the front portion of that disc gets pinched right here, okay? And when it does that, it pushes the gel-like structure posteriorly to the back, and it creates a posterior pressure there. And if you got a nice healthy disc, that's probably not a problem. But if you have a disc that's not healthy in this and weak in that position, then we may have a problem, which we're going to see in just a second. So most oftentimes, forward flexion is the thing that causes the greatest amount of pinching of our disc, which causes the greatest amount of posterior pressuring of that gel inside the disc, which now makes us prone to these herniated discs that we're going to talk about. If I go into extension of my back, on the other hand, the things that stop me from going into extension are not the disc, but actually it's these joints right here. When you have two vertebrae sitting one on top of the other, they form what are called a facet joint, and they lock in place. So we actually get a bony lock. So here's the posterior of the joint here, like this, right? And those are the spinous processes we're talking about. And when they go into extension, these bones actually lock in place, and they don't stop. They stop from going any further, which means we don't get nearly as much pinching on the back of our disc here, and we don't get as much of that migration or pushing of the gel anteriorly. So the bottom line to all of that is, when it comes to disc injuries, we're much more vulnerable to disc injuries with forward flexion, being in a flexed position, all right? Because we have this more of a pushing of the disc backwards than we do this way. On the other hand, if we have an injury when we have an extension of our problem, then we probably have the problem where these joints are locking up. And we're going to look at those two in separate right away. All right, so here we are again, the similar type of picture. And now what I'm going to talk to you about are the facet joints. And those facet joints are these. So we looked at the body, the disc, right? There's that hole where the nerve is going to come through. But each vertebrae they actually have four of them. They have two on top, one on the left and right, and two on the bottom. And so this portion of the bone, this portion here, locks into the top portion of the lower bone. So that's where these two bones come together. And I don't know if I can bring it in close enough for you to see a facet joint, but that would be the facet joint right there, okay? When they lock back in place like that. And so they lock into place, and they provide you with some stability, side-to-side stability, but they'll also allow forward flexion to occur. So, and an extension is where that locking happens. Well, we can cause overextension. We can irritate this joint. And the important thing to remember about this joint is that we refer to as a facet joint. If you really want to impress your physicians, it's called a zygoapophyseal joint or a Z joint, zygoapophyseal joint. But we typically refer to as a facet joint. And so you'll have conditions called facet joint syndromes. And the key to the facet joint itself, these two vertebrae, these two bony surfaces, when they come together, they're actually they're encapsulated with a capsule, just like your knee and your ankle is. And that capsule, it's referred to as a synovial capsule. That capsule secretes fluid, and it lubricates the joint so that we don't get any wear and tear back and forth. And when we do all these flexion, extension, and rotation, we're not wearing and tearing the bone. We got the joint there. The unfortunate thing is, so we have this capsule that wraps around this whole joint like that, right? Well, when you get injury to this, the capsule swells. It increases, because that's the only thing it knows how to do, is make fluid. And says, you've been injured, I'm going to create all this fluid and I'm going to splint you. It's its own natural cast. It's going to say, I'm going to splint you so you can't move until whatever is solved gets better. And essentially that's kind of what I'm going through right now, where I've got one joint right now that it's swollen, and it's trying to protect me from not moving. And, I'm moving more than I should be. But that's what it's trying to do. It's trying to stop me from doing that. But in the process of doing that, it can swell so much that now it swells into that hole, right? And we had the nerve coming through that hole. So it can pinch on the nerve, and now we can give neurological pain. So in my case, I don't have that. It's not pinching on a nerve. I don't have any neurological pain. It's just local at that joint. And it hurts mostly when I go into extension. In fact, when I go into flexion, it feels way better. But if I try and go into extension, I got this pain because I'm locking these two bones together, and it's not a pleasant feeling. All right. So this would be a facet joint problem, and most of the time, the person will have most pain in extension versus flexion. All right. Okay. Now we're going to step back just a little bit there. We saw the facet joints. This is the top portion of one of those surfaces. The other bone would come down, and the bottom process would articulate there. But here's our spinal cord coming through the hole. This is the spinal cord, and here's the nerve root going out through the left and through the right. All right. And so, and obviously, if we had the other bone on top, we'd have a hole there. And so we would have this facet joint right here. And if that facet joint swelled up, it would put pressure on the nerve. And when you put pressure on the nerve, I get shooting pains, and I get numbness, and I get tingling, etc. All right. So this terminal nerve, this nerve root is problematic. It can give us an awful lot of pain when we have back pain. I'm going to go past that one and just go down to here and show you now. Now we're down really low down in the spine here. You're starting to learn your anatomy. Here's the tailbone, right? And this is your L1 and L5 lumbar vertebrae. And here's one of those nerve roots coming out between L3 and L4. And here's another one coming between L4 and L5. And they actually, when they leave, they actually join. They join up, and they join up with some of the nerves coming from the sacrum. And they create this nerve. And we're going to see this nerve. You've heard this nerve before. You've heard of people getting sciatica. So this is the sciatic nerve, right? So if I had a disc that was pushing over here, or I have a facet joint over here pushing on L4, I would now affect the sciatic nerve, and I would get sciatic-like pain. I showed you, I have this picture here down below to kind of show you another picture of it. So we're looking at this. This is from the front. Now we're looking at it from the back. You see the back of the tailbone, of the sacrum. And you see the sciatic nerve coming out there, down the back behind your hip, in your cheek muscle. It goes down behind in your cheek muscle, all the way down the back of your leg, all the way down to your foot. And we're going to talk a little bit about this muscle later on. This is called the piriformis muscle. That now can be also a thing that can put pressure on that nerve. But you're kind of seeing the nerve leaving the spinal cord, leaving the pelvis, going down the whole of the leg, and it feeds all the muscles of the back of the leg, this particular one. And there is another muscle that leaves the front and feeds the muscles of the front of the leg. All right. So that's kind of anatomy. You've looked at bone, we've looked at the disc, we looked at facet joints, we've looked at nerve, and now let's just look at a little bit of mechanism of injury. And check and see what kind of time I have. Ooh, quick. All right. So mechanism of injury. Oftentimes it can be traumatic. Obviously, if you have a fall, car accident, etc., you can have it traumatic. But more often than not, it's progressive in nature. And this is an important thing. More often than not, this is an accident this is an injury that is progressively getting worse, and you don't know anything about it. And the reason for that is the disc that we talked about has no pain fibers in it. And it has no blood supply in it, other than its very outer rim. All right. And so when you start doing damage to the disc, you're not being told. It's not being aware of it. So let's look at that disc right away. Here's our disc. And here we're looking at it now, a different illustration of it. So now you know these are those lamellar rings, and there are hundreds of them there. And this is that nucleus pulposus. Now, when I say it's progressive, it means that what happens is that progressively we start to damage these inner rings, these rings, okay? So remember that if you had a fall, or you twisted wrong, or you went to lift something really heavy, and you create a lot of pressure inside that disc, you create the pressure, and that pressure, then this nucleus pulposus get pushed backwards, and it does damage to the innermost layer. So let's say it just does that damage to that layer there, it ripped it, okay, as we're seeing. You don't know that because there are no nerve fibers there. So there's no warning signs that we have here. And so then, a month or two later, you're shoveling snow, and you do something again where you'd rotate the wrong way and you damage again another layer, but you don't know. And all the while you're doing that, every time this is found a release point, it's moving in that direction. And you tear and you tear and you tear. And eventually this thing is moving. And eventually what happens is it gets to the outermost layer. And now that outermost layer has pain fibers. And you start feeling, I have back pain. My back is sore. But you don't really do anything too much about it because there's no real major sign. You still got function, etc. You might take a Tylenol, or you might do something to put ice on it or something. But then one day you do something that you've done 1,000 times before. A friend of mine, I remember, was an electrician. It happened to him when he went to pick up his toolbox off the floor. And he says, I've picked up my toolbox off the floor like 100,000 times in my lifetime. Why did it have to happen that day? Well, here's what happened. So in those 100,000 times, he was tearing and tearing and tearing. And eventually he got to just the very last portions of that disc. And it's now sitting there and it's pushing against this wall of fluid that wants to come out. And it's pushing and pushing, and it just can't do it anymore. And then he goes and picks up that toolbox with that forward flex position, with pushing the pressure backwards. And sure enough, the dam breaks. And now this stuff comes pushing out, and now it puts pressure on that nerve. And now the alarm bells go off. Okay? So the moral of the story here is it wasn't that one time picking up the toolbox. It was the 100 times doing it incorrectly, or the amount of times that he did other things that caused these progressive tearing of the rings. So the moral of the story is, we know this is happening to all of us. It's a progressive thing. And what we want to be able to do now is take steps to prevent it. So that's an important thing. Okay? Now, I'm not going to go through a lot of spinal stenosis other than to say spinal stenosis is another way that we pinch these nerves. And that means, stenosis means narrowing. It just simply means narrowing of that intervertebral foramen, for example, that side vertebrae. So here's another picture of the facet joint here. This is what's called an intervertebral stenosis. You already know about the intervertebral foramen, where that nerve comes out. And so a stenosis just means it narrowed. Why did it narrow? Well, one of the reasons we know already is that this disc, if this disc gets thinner, then these two vertebrae come closer together, the space gets narrower, and I pinch the nerve. We also know that if this facet joint that you have here, if that gets irritated and it swells, it now encroaches on the hole and creates a stenosis, pinches the nerve. Another way, the third way that this can happen, is that the bone itself, see how angry this bone looks? It's all red and it's got lots of blood flow coming in. The reason why it's like that is because this disc is not doing its job anymore. It's not absorbing load anymore. It's not working as a shock absorber anymore. It's diseased and it's too thin. And so what happens is that the bone says, well, I need to do something and I need to become stronger. So it brings more blood flow into the area and starts to grow new bone, but it doesn't do a very good job of it. It grows new bone in really rough points. So if you look at, for example, right there, that's a bony spur right there. There's a bony spur right here, okay? And that bony spur has to be pushing down into that intervertebral foramen and on that nerve root. So now not only is it just a joint swelling or a disc compressing, it's actually the bone growing new bone pushing on it. And that becomes much more of a problem, because how do you fix that? Okay. Maybe I'm just going to go. Yeah. Okay. Oh, there was one thing more I wanted. Okay, let me just go back to that. So this is just another picture here of the disc getting narrower. And see how this is a nice healthy disc here. The disc gets narrower. We have a disc that herniates over here, narrow. Look how when it gets narrow, there's no disc anymore. And look at the bone, and look at how that bone grows all these little osteophytes, right? And look at how that osteophyte can now go in and impinge inside that foramen. And look how the foramen is getting smaller and smaller and smaller. So this is a progressive degeneration. Why? Because the vertebrae, the disc is not doing the job it's supposed to be doing, and it's failing. All right. I mentioned this Piriformis Syndrome. This is, again, this picture now. We've got muscles in here, and there's that piriformis muscle right over there, right? And that's the sciatic nerve. And the reason why I say this is because sometimes we get sciatic-like pain that is not related to our spine. It's not related to that. It's related to this particular muscle in your hip. It's called the piriformis muscle. And it happens to be that the nerve runs right underneath that. So if this muscle goes into spasm or shortens for any reason and puts pressure on the nerve, then you get pain down your leg as well. So it's not always because it's coming from the spine. It can be coming from this particular muscle as well, which is why you want, and you have this pain, you need to make sure that you have a real good assessment and find out what the actual cause of the problem is. All right. I know we're getting short on time. I just want to talk quickly about treatment, things that you can do for treatment. Obviously, there's medication, and there are all kinds of different types of medication. You can take medication for pain. You can take medication for inflammation. If you've got muscle spasms, you can take muscle relaxants. Many medications have a combination of two of these. They'll be for pain and inflammation, or pain and a muscle relaxant, or an anti-inflammatory. So those are treatments that provide you with a certain amount of quality of life. The thing that gets me is that I watch these commercials, and this poor person can hardly move because it's the movement that caused their problem. And now you say, well, I'm going to give you this medication that's now going to alleviate all the symptoms. And now you can go back and do the same things that caused the problem in the first place. So that's not the way it's supposed to be. What it is, it's supposed to give you some quality of life. It's supposed to give you respite from your symptoms while the body is healing. And so it's not a question of taking medication and say, okay, well, now I can go back and do all the same things, go back and shovel my driveway again because I took medication. Or worse yet, take the medication in anticipation that's going to be painful and go and do your work. Okay, that's even worse because all you've done is mask the symptoms. So yes, you're in pain. Yes, you want to take some medication to try and relieve that. A physician will prescribe you that. But it also means you need to take some time to allow the body to do its recovery. Even though you don't have the symptoms, the injury is still there. These medications do not solve the problem. They mask the symptoms. All right. On the other hand, you can also have therapy, and there's a whole array of therapies that you can have. You can use ice. You can use heat. The age-old question of whether you want ice or heat. Ice is a very good modulator of pain. So if your objective is that you want to relieve your pain, ice is the answer. If your objective is I feel stiff and I want to have I just feel like I'm rigid and I want to move, then heat can help. The fallback position, if you're ever in doubt, use ice. Because ice will do the same thing. It will eventually give you that relief of muscle spasms as well. So the first go-to thing is ice. Certainly in the acute phase, in the first 2 or 3 days of injury, you want to use ice and you want to avoid heat. All right. You can do massage. You can have a massage therapist. There are things like TENS units that you can have. I know you can buy those things on the market right now. You just want to make sure that you know how to use these things properly. But again, they are all symptom relievers. They do not solve the problem. The massage will help with the muscle spasm you get. It might help with some of the relief of the injury. You can do acupuncture. Again, it's a pain modulator. Exercise will be very, very important. The worst thing you can do is go and spend 2 weeks in bed. You need to move. Okay, you need to, and then there's all things like chiropractic, and there are many, many other types of modalities. But you want to make sure that these things make sense, that they're proven, that they're by a certified person. And when you talk about what's this going to do, how's it going to work, then they need to be able to explain it to you in terms that make sense to you. And then you should be seeing some of that relief in the short term. 2, 3, 4 treatments. And if you don't, then you should be questioning whether or not that treatment is appropriate or not. Okay. Just a small thing on back supports. I have no problem with back supports in the very, very short term. And they do something, they replicate what your muscles are supposed to be doing. So they do create some pressure. They provide you with a little bit of that stability and decrease the mobility while the spine is healing, but very, very short term. And when I say short term, a week to 10 days, maybe 2 weeks at the outside. but you need to move away from those, and you need to start to develop your own back support, which are your muscles. We'll look at that in a second. Okay, the resting positions, you are going to know what the position is that's most restful for you, because you're going to try it and it's going to be pain-free, and you say, there it is. But generally speaking, getting into a position like this is called a hook lying or a crook lying position. It just rotates your pelvis. It flexes your spine a little bit, takes some of the pressure off of it. Obviously, lying down on your back, you're taking off the force of gravity, so you don't have the compressive loads on your disc. That's a good thing. If you're a side lying person, then you want to make sure that your spine is a nice straight alignment. You don't want it curving in that position, like sideways curving. You want it to keep it nice and straight. So pillow for your head, pillow between your knees so your pelvis is nice and level, and having a pillow in front so that you've got something to lean up against that keeps you in an upright position. Those are the types of things you can look for. Okay. Another treatment you can have, and this is again something after a lot of other things have failed, then a physician may suggest that you get an injection. So this will be an anti-inflammatory cortisone injection into the spine or into the facet joint or right into the spinal cord. Not the spinal cord, but in the space in the spinal cord. These are all things that are they're invasive. They should be things that you should be trying at the if all else has failed, and your physician obviously is the one who's recommending you do that. Okay. Even further on down the line is surgery, and here's your disc again, and here's that ruptured disc pushing on the nerve. And so what happened here in this case was that the disc was pushing on the nerve, but there was a bone right here. Okay, there was a bone right here. So this bone here was over there. And so that nerve was pushing up against the bone, the disc was pushing at the nerve, and it was compressing it. So one way of relieving the pressure is to cut that bone out. That's a surgical procedure, right? It's called a laminectomy. And here's the procedure where they take that piece of bone out, and now it gives space for the nerve to just recoil or push backwards and take the pressure off of it. But you can obviously see this is a significant surgery, and oftentimes it's tied in with the fact that now, because they've taken this away, they've rendered this joint, these vertebrae, more unstable. So sometimes they will come in and they will bolt them down with rods and screws and fuse it. And of course, now you've lost the mobility of this joint, but you've maintained the height of it. So again, a significant type of treatment. These are things that are available, not so much in Manitoba right now, but this is what's coming down the pipe, where you can get artificial disc replacements. And you can have these done in Germany, I know for sure, $50,000 for one disc to have that surgery done. So again, these are going to be things that are going to be something we're going to look for. In terms of prevention, the key here, prevention, are going to be things like posture. So I'm just going to bring you quickly. Now you kind of know that if I have a curvature in my spine this way, or if I have too much of a curve in my spine this way, or if I have, like, look at the kind of curve that I have this way, then that means that not every one of the vertebrae are doing their job. That means that, and usually it's at the apex of the curve. So if it'd be there. So let's just say that this curve is going from the 10th thoracic vertebrae down to the 5th. And so this is at L3, let's say. That means L3 is doing all the work, and L4 and L5 and T1 and T2 and L1 are not doing very much work. And this one's doing all the work, and it's the one that's going to fail. All right. So if we have poor posture, then we're putting all this load on one or maybe two vertebrae of our spine, and we're breaking it down progressively. We don't even know what's happening, but eventually we're going to get that situation. So this is a bad posture. This is a bad posture with that lordotic curve there. What we're trying to do is create a posture straight up and down so that every vertebrae does its share of the load, and none of them break down at an accelerated rate. So we're now preventing this inevitable wear and tear that happens that we get. The same thing with sitting. If you're sitting in this posture, you now know forward flex position. What are you doing to that disc? You're pushing that gel backwards. You're putting all that pressure on those rings, and you're getting progressive wear and tear, and you're not even aware of it. Okay. Whereas what you want to do, again, nice straight line, every vertebrae doing their job. Okay. Sleeping postures are the same. So making sure that ideal sleeping posture is sleeping on your back. Don't necessarily have to have your feet up in here, but if you have back problems, this is a very good way to sleep because it's that resting position. Making sure that your neck is properly supported with a proper pillow. So here's in this case, they've got like a cervical pillow. In other cases, you might have a wedge the other way, particularly if you have a hiatus hernia. Side flexion, we talked about already, but the worst thing you can do is sleeping on your stomach. Okay. Sleeping on your stomach, your back is in that lordotic position, and you also have to breathe. So breathing means you've got to turn your head. So now you've got your head, your cervical spine rotated one way, compressing one side, stressing the other. There's all kinds of things that are happening when you sleep on your stomach that just are not healthy. One of which is also that you've compressed your rib cage. So your rib cage can't expand properly. Therefore, you can't take enough breath at nighttime so that you're not getting enough oxygen at nighttime to sleep. And then you've got all these mechanical things that are happening. And more often than not, people sleep with their hands above their head. And that now causes all kinds of chronic impingements in their shoulders. Now, core stability is important. Stomach, when we talk about core stability, we're talking about the stomach. These are the muscles that we're talking about. There are 4 of them. This one in particular is really important because it's the way that it runs, its fibers run horizontal. It's the deepest of the 4 muscles in your stomach. And this is the one that replicates that corset strap, that belt that I was talking to you about. So what you want to be able to do is have a good, strong muscle there and be able to pull your stomach in and create that pressure in your stomach. And that's what protects your spine. So having good stomach, we typically say that the best way to treat a back injury is to treat the stomach, right? Treat the core. So treating these muscles in here. And these are a fellow by the name of Stu McGill has coined the McGill Big 3. These are the 3 muscle exercises that are most prevalent for stability of the spine, of the stomach. So this is just a curl up. He doesn't advocate you do a full sit up because obviously now you know when you do a full sit up, that's flexing the spine, that's putting pressure on that disc, putting pressure on that nucleus pulposus. So it's creating more pressure on the back of the spine. So he's saying, no, let's engage these stomach muscles without getting much flexion inside of our spine. So hands underneath your back, and you lift your head and your shoulders, but you don't actually cause a curl. But you have engaged all those muscles to do that, all right? One leg up in here because it just helps you posteriorly rotate your pelvis and flatten your back so we don't get lots of arching in our back. And then this is an exercise where you're focusing on tightening up your stomach muscles, keeping them nice and tight while you put yourself off in an unbalanced position. So we're not really exercising the arms and the legs here, and we're not really exercising the hip. We're exercising the stomach muscle. So when you do these 2 positions, like left arm and right leg, your back should not move. It should stay still. It should not collapse. So that you're concentrating, even though you're moving your arms and leg, you're concentrating on your stomach muscles. Okay. And then this one here is the work on the muscles, stomach muscles from the side. So this would be a plank. Now you can start with a plank on your feet this way, or you can actually go down onto your knees and do the plank that way. You'd have to do both left and right to do that. So these are all excellent exercises for core stability of the back. And then flexibility is really important, particularly doing low back stretches with your knees to chest, and doing hamstring exercises are very, very, very important. And also critically important are muscles of your calves. And I'll just say that if any of you want some exercises like this, you can send me an email and I will send you some exercises. And then we have the lifting techniques. I'm just going to go to discard. Okay. The only reason why I want to do this is because I want to be able to stop this thing. So the key to this is, here, okay? So I've got these 2 little stick figures that are moving. And in this one here, they're moving with a straight leg. When you move with a straight leg, all the force is occurring on your lumbar. I guess I don't have my little pen when I do this. Oops. Let me just do there. Huh. Sorry about that. Let me go back and find it. you know. All right. So let's play them a bit. Okay. Okay. So when you're doing with straight leg, all your force is in your lumbar spine. This is all the stress being applied here. When you do it with bent knees, the forces are being around your hip. You have lots of muscle in your hip to be able to do this work. You have very little muscle here. So it's easy, very easy to strain your back and put pressure on those discs when you do this. Whereas if you're doing it with a bent knee, back is relatively straight and you don't put that forward pressure on your disc. So the bottom line to that is that lifting techniques are really, really important. Bent knee, bent hip positions. If you're lifting a heavy weight, make sure you keep it in close towards you, because the further you have it out, the more leverage you create, the more arching you create on your back. All right. So lifting is very, very important. You now know that lying down, sleeping is posture is important. You know that sitting posture is very important. And so I'm giving you some of those insights into some of the things that are happening there. And hopefully now you got some of the reasons why, rather than just me saying, you do this because I told you, you kind of understand the reasons why. So I know that went really fast and I know we're a little over time, but I am open to some questions.
Wonderful. Thank you so much, Dr. Bergeron. That was fantastic. I learned so much and it was very insightful, right from anatomy all the way to the treatment. It was really nice to hear the whole picture of why back pain happens.
Great. I'm glad that was helpful.
Very. So I'm just going to give people a little bit of time. The chat box is open. If there is any questions, please put them in there. If you're not comfortable typing them out, by all means, unmute yourself and you can ask a question.
Yeah.
I actually have a question, if that's all right. You kind of, you went through quite a bit of different kinds of treatments, and the one that I think is a bit controversial sometimes is chiropractic care. And I was just curious of your thoughts on that.
There's I guess it's kind of like a chicken and the egg kind of process. So that the nice thing about chiropractic is that you can get some immediate relief, but you got to stop and think about what caused the problem. So oftentimes it's kind of a chicken and the egg. So I, as a soft tissue person, as a therapist or a massage therapist, will also say that the reason why these facet joints are locked up is because the muscles themselves have gone into spasm, and now they've caused a bit of a malalignment of your vertebrae. They're like guy wires on a telephone pole. That one of the muscles on one side is too tight and it's twisted your vertebrae, and it now has caused the facet joint that we talked about, to compress and cause this reaction of swelling. And so, as a soft tissue person, I'm going to say, well, I'm going to go in and I'm going to release the muscle itself and go to what I think is the root cause of the problem, and release that tension on there, and then allow that vertebrae to now realign itself, or even through motion and mobilization, you can help the realignment. And so the spasm, if you take away the spasm, then it should be gone. A chiropractor will say, well, one of the reasons why they're happening is because the joint is malaligned and putting the pressure on the nerve, and it's the nerve that's causing the muscle spasm. And so if I go and I realign the joint and take the pressure off the nerve stops being impinged, the muscle spasm releases. So it's the chicken and the egg sort of picture there. And my experience has been that chiropractic care, the sort of the allure of chiropractic care is that when I do that little manipulation, I take the pressure off, the pain goes away almost immediately, which is really a nice selling feature. But oftentimes what happens is that a day or two later, it comes back again because the muscle spasm is still there. And now the realignment gets re-engaged, and I get so now I've got to go back and get a manipulation done. So it ends up being that we may be relying on, cumulative manipulative treatments to get this, and whether or not we get a full satisfaction of releasing that spasm is a point of, debate amongst the health professionals. So my way of thinking is I will work on the muscle, and I will tell a person that the relief is not going to be as quickly as they want it to be, but by my way of thinking, it's going to be longer lasting. You're not going to have to come back and repeatedly get treatments from me.
Makes sense.
Yeah.
Thank you. That's great. Did anybody else have any other questions? Well, we've gone fairly over time today, but it was fantastic. The content was wonderful. So I don't want to take up too much more of your evening and everyone else's evening. So if there aren't any questions.
There was one here from Stanley. Oh. Stanley asked something about low intensity laser therapy, an effective pain relief modality. You know, Stanley, there's an awful lot. There are a lot of places that are opening up with low level laser. Oops, stop that. Sorry. That have low laser therapy, but the research for it is really not conclusive. First of all, laser doesn't penetrate very deep through the skin, so there is good evidence that laser works well on skin lesions, on infections and wound healing, because it does have an effect on the skin level. But what happens beneath the skin level is really open to further research. There's conflicting things in terms of whether or not it works or not. We have laser in our clinic, and we use it mostly for superficial type things, for tendon injuries, etc. And we don't necessarily use it for low back pain. But again, some people will go in and get laser therapy, and they feel like it's wonderful. So I can't tell you that the research is really there to say yes, 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 and you need these parameters. Just be using caution. And again, if you're getting that kind of treatment, you should be getting some sort of relief within 2, 3, 4 treatments. And if you're not, then you should question the efficacy of that and whether or not you should continue. So question here is, should we avoid bending down as downward dog and touching toes? So this is a question that I get asked often. Anatomically, we are designed to be able to bend forward. So it's okay to do those exercises. It's just not okay to do them repetitively and dynamically. So you're designed to go into forward flexion. And so you do want to do that. So it's okay to do them, but you want to make sure you do them under control. You want to make sure you have good core stabilization. You've stabilized that corset that you have on your stomach when you do the exercise. And you don't want to do it dynamically, which means real ballistic type motions, fast rotations, etc., unless you're really well warmed up. And you also don't want to do things repetitively. Like if you did 3, 4, 5, upwards of maybe 10 in a day, you're probably okay. If you're doing 153, probably too much.
That's good to know. You talked a bit about the waist trainer, and I'm just curious, so many people use them when lifting heavy. Is that taking over for the muscles that you have? Is it, because you kind of said it should be a temporary thing, or is it good for weightlifting? Well,
with weightlifters, they use it as a complement to their abdominal strength, because they know that they're going to be lifting weights that are well beyond the normal. And so they're just this is added protection for them. But it's not saying, well, I have to do this because I don't have any good muscle strength. If that's the case, you shouldn't be doing it, because you need to have, if you're doing lots of weight training, you need to have the core stability. And in addition, you have to have this belt if you're doing heavy weights. Now, if you're doing weightlifting, that we would do just for general muscle toning, 5, 10, 15, 20 pound workouts, then probably not, right? But if you're having to do a real maximum exertion, then you're saying, okay, I'm working my core muscles to the max, and I want to make sure that I give it this added level of protection. And that's why you see power lifters and competitive lifters wear those.
Perfect. Thank you. Answered all the questions. This is good. If anybody has any other ones, please put them in the box now. Oh, there's another one. Do you advise against deadlift exercise?
Yeah, I'm not a fan of deadlift exercises, but I may be in the minority. And the reason why is exactly what I said about that lifting technique when you're doing your lift with a straight leg and doing it. And proponents of deadlifts will say, well, you're using your hip extensions to do the work. But first of all, you have to make sure you're doing it very well. You have to have good core stabilization to do that exercise, because it is a risky and dangerous exercise, because all the pressure is being applied to your lumbosacral spine and not onto your hips. And so I'm not a big fan of them. But I know that you're going to find people out there who are going to say, it's a wonderful exercise. So I can't give you a definitive. I'll just tell you what I think.
Interesting. You've given us a lot to think about. I'm thinking about everything that I do in exercising now and just how the flexion and extension is happening. And even while sitting here the whole evening listening to you talk, I'm straightening myself out. And I'm sure other people might have.
Mission accomplished then. That's great.
Good. It's great. It's a good reminder for sure for everyone. Okay. Anybody else for questions? Oh, there's a hand clap from someone. Wonderful. Oh, that's good.
Yeah, I guess the thing that, the important take-home message of all this is recognize that this deterioration of your spine is happening, and we have the power to slow it down. And we do that by good posture, both sitting, sleeping, and standing, or all three. And making sure we do that. Make sure that we have good core stability, so that when you're standing, you're taking some of that pressure off your spine. And sitting, you're sitting with this core nice and tight, core support that you're having through your abdominal muscles, and good lifting techniques. Make sure that you do all those type of things. Even like shoveling, you shouldn't be doing shoveling in rotation. Some of us are at the age where we have grandkids, and they're all going to come running up to you, and you want to bend down, and you're bending down at the hips to pick them up. Very dangerous type of thing to do, because they're coming in dynamically and they're just going to bowl you over, and you're not going to be able to control your spine. So you got to be careful about that. So make sure you get down to their level with a bent knee and bent hip, and receive that, the child coming to you, instead of trying to bend at the hip to do that. These are simple things. If you're a young mother reaching over the top of a crib to get a baby, again, same thing. Those are type of things that are problematic. So there's lots of things in the course of the day when you stop and think, oh, I probably shouldn't be doing that.
So true. Very true. Anybody else for a question? I think we're heading to the end here. And of course, if you have any other questions that pop up later on, be sure to send them our way via email or Facebook, and we'll be happy to contact Dr. Bergeron. And there, oh, perfect. There's his email there as well, if you'd like to contact him. Yeah, I just want to also say thank you so much once again for doing this evening, and answering all these great questions. And thank you to everyone for joining in this evening. It's fantastic to see you all here. Be sure to join us next week. We have How You Can Combat Ageism with Michelle Porter. That's on Tuesday. That's our next one. And if there are no other questions, then I will say thank you again. And it's been wonderful chatting this evening.
Thanks, everybody.
Have a wonderful evening, and we'll see you all next week. Take care.